and Wolfgang, Henrich is going to be discussing now the value of ultrasound after delivery. Wolfgang?
Okay. So, yes, dear Rasha, thank you so much, dear Kypros. Ladies and gentlemen, thank you very much for the opportunity to present a lecture about now postpartum ultrasound at such a high-level international online meeting. You can see in this slide my team of the Charité. We have to manage together approximately 5,500 deliveries with a high proportion of high-risk pregnancies. Especially for you, Kypros, the influence you had on my career is one of the reasons why I am where I am today. Starting 30 years ago, OBGYN, I was very happy to receive 2005 the diploma in fetal medicine from you and Eve. And when I crossed over from the prenatal diagnostic into clinical obstetrics on the labor ward, I brought this knowledge with me because of my passion of ultrasound into the delivery room. And here you can see on the left side, as early 2004, I started during intrapartum ultrasound to identify landmarks that would improve our understanding of the second stage of labor. And as Boris just said, it is extremely important if you measure and look at these findings in rest, during contraction, or during pushing. So this makes it very different. And if he described the transition from obstetrical ultrasound to ultrasonographic obstetrics in an editorial in the White Journal already 2006. But now let's focus on my topic. And before I will guide you through some cases where ultrasound is very useful and beneficial in the diagnosis of different causes of postpartum hemorrhage. Seems to be a little bit boring issue, but I promise you it's not. The first thing is, for babies are born every second in the world. So it means we are not dealing with a syndrome which occurs 1 in 50,000 or something like that. It's really a relevant thing. 4% of women bleed more than 1 liter during delivery. And every 4 minutes, a woman dies of peripartum hemorrhage, with all the consequences for the family, the baby, sisters, mothers, etc. Postpartum hemorrhage is one of the 4 major causes of maternal mortality, if not the number 1. And you know all the 4 T's: atony of the uterus, the major cause, retention of placenta or remnants, trauma of the uterus, cervix, vagina, and coagulation problems. Now, I want to guide you through some cases where the use of ultrasound is beneficial, and I show you the first case. The first case was a patient with severe peripartum hemorrhage caused by atony and retained placenta after a planned home delivery. Some stupid idea, I think, but still 2% of the women think it's much better to stay at home for delivery. She was found by her husband on the bathroom floor in hemorrhagic shock. He called the emergency doctors, who transferred the patient unconscious and intubated directly to our hospital. Now you can see the patient here in the operating theater, and the first view of a transxiphoidal 4-chamber view heart helped us to evaluate the cardiac contractility of both ventricles. You can visualize the right ventricle closer to the transducer. Both ventricles have reduced filling as a sign of hypovolemia caused by the severe blood loss. Both ventricles have regular contractility, and in the absence of right ventricle dilatation, a severe acute thromboembolism or amnion fluid embolism is unlikely. In thromboembolism or amnion fluid embolism, you would have to expect pulmonary hypertension with a significant dilatation of the right ventricle. On the other hand, the left ventricle is regular. It is the regular contractility of the left ventricle rules out severe left heart failure, which can occur in cases with cardiomyopathy or cardiac infarction. And besides the cardiac regular activity, we can see some mild pericardial effusion. After the quick evaluation of the maternal heart, it's easy to examine the maternal liver to rule out liver hematoma, perihepatic fluid. A liver hematoma can occur in patients with exacerbated HELLP syndrome. In case of hematoperitoneum, it is possible to visualize echographic fluid around the liver and the Morrison pouch between the right kidney and the lower lobe of the liver. An amount of 10 milliliter fluid collection in the Morrison pouch correlates with approximately 1 liter of abdominal fluid. Then in the lower abdomen, it's possible to visualize the entire uterus. With an empty uterine cavity, the retained placenta of the patient was removed at the beginning of the examination. The balloon of the Foley catheter is in the empty bladder. The myometrium of the anterior and posterior wall is thick and intact, so that a rupture of the uterus is unlikely. At the end of the examination, the maternal heart still has regular rhythm, frequency, contractility. And with these findings in this fast sonography, the further need for an abdominal intervention is very unlikely. And if the patient stays in unconscious status, it would be necessary to do a CT of the head, of the skull, to rule out intracerebral hemorrhage or bleeding. Now, I hope I convinced you a little bit that ultrasound is very necessary in the obstetrical department and on the labor ward. So to show you just 3 examples of a hematoperitoneum, very easy for a trainee to detect around the liver, the free fluid, or a hematoma. I experienced that patient here. She was in an exacerbated HELLP syndrome, and it's absolutely recommended immediately to deliver these patients by C-section, otherwise the mortality is extremely high for the fetus and the mother. And in this case, I experienced a patient with an amnion fluid embolism, and you can see here the right atrium, the right ventricle, and the left ventricle. And you can see the pulmonary hypertension leads to a deviation of the septum into the left ventricle, and this leads to hypotension, tachycardia, and the bad status of the patient in amnion fluid embolism. Now let's go back to the basics. In this case, I will demonstrate the ultrasound of a placenta which is just delivered, because birth is not over until the placenta is delivered. I would like to remind trainees that this phase of delivery can also to be observed with ultrasound. Familiarity with the normal postpartum ultrasonographic findings is necessary in order to recognize signs associated with PPH. In the left video clip, the contraction of the myometrium is visible, and in the right video clip, you can see the expulsion and delivery of the entire placenta. These 2 clips correlate perfectly with the MRI images which were taken during the first and only human birth in MRI at Charité University Hospital, which were just shown by my friend Boris Suchek. Now, in the next case, and this was never proven by a study, I will demonstrate the ultrasound-guided manual removal of a placenta as well as the documentation of the empty cavity after the procedure. An assistant visualized by transabdominal ultrasound in a sagittal view, the manual maneuver and the removal of the entire placenta. If further instrumental intervention is necessary, an ultrasound-guided postpartum curettage for the removal of partially retained placenta tissue is demonstrated. By transabdominal ultrasound in the sagittal view, the metal instruments can be easily visualized, and the co-obstetrician can be guided by the sonographer to localize the areas of interest with placental tissue and avoid complications, for example, perforation of the soft uterine wall. Finally, an image of the anti-uterine cavity can be documented. Now, a perforation of the uterine wall can be seen in this case, developed in the anterior uterine wall following a postpartum curettage without ultrasound guidance 8 weeks after delivery. The laparoscopic images show blood clots in the abdominal cavity as well as a perforation close to the vesico-uterine fold. Now, what is about uterine atony? From my perspective, we have two types of uterine atony. One type is just the limp uterus after 48 hours induction, protracted labor, vacuum extraction, etc. And the other type is the one you can detect by ultrasound. In this patient, we visualized an open spiral artery as a cause of persistent refilling of the uterine cavity in a well-contracted uterus without evidence of placental tissue. With color Doppler detected a pulsed arterial vessel refilling the uterine arteries. These are the ones where the bleeding comes again and again despite well-contracting myometrium. So how can we solve the problem? We can solve the problem by the application of an FDA-licensed treatment with a Bakri balloon is possible and demonstrated by transabdominal ultrasound, by transvaginal ultrasound, and 24 hours, the balloon can be removed 24 hours later, and we never experience any repeated bleeding after the removal of a Bakri balloon. However, an alternative is the off-label use of a not so very well-known Celox gauze tamponade. And I have to emphasize that I have no conflicts of interest with this company because the product is not FDA approved, because it is a well-known on the battlefield of war to stop intractable bleeding. The uterine blood flow is shown by color flow here in this case again, and with pulse wave Doppler as well in a patient following a 24 weeks late miscarriage with manual placental removal and continuous bleeding. You can see here the placenta bed bleeding by color Doppler. And despite tranexamic acid we applicate in these cases, despite prostaglandins, the bleeding didn't stop. So what we did, we inserted gently, and this is an assistant, a trainee, with a tissue forceps, the Celox tamponade into the uterine cavity, up to the uterine fundus, again guided by ultrasound. The blood loss is measured accurately after collection, and finally, the correct position of the tamponade can be shown by ultrasound. Now, I want to explain you the mechanism of this, for me, game changer in obstetrics. By this clip, it's a video clip from YouTube, free, accessible, and let's listen a couple seconds how it works.
Hemostatic agents work by accelerating the body's own clotting factors, but these can become compromised in severely bleeding casualties. Celox is different. It works independent of the blood's intrinsic clotting mechanism. Celox works physically at the source of bleeding. Celox gauze absorbs blood fluid, swells and forms a gel-like plug that covers the wound and stops the bleeding. Celox gauze is presented in a light.
So we performed a comparative study between Bakri and Celox and came to the conclusion that Celox was actually superior to the balloon tamponade, and I will explain you in my next slide why. The application of Celox is much easier. We haven't seen any dislocation, which sometimes occurs, especially after spontaneous deliveries when the cervix is fully dilated, and dilated balloons, they have the tendency to slip out. And the major advantage is a local hemostyptic effect. And this is the game changer here. We have less pain for the mother because we do not dilate the organ which we actually want to contract. And we have the option also to use the tamponade intravaginally. So these are the big advantages. And what we have to do then, after 24 hours, we remove it the same as we remove the balloon. And you can see here the ultrasound guidance removal of the tamponade 24 hours later. The bleeding had stopped immediately. This patient lost 1.5 liter blood during her spontaneous delivery. And you can see now the removal, how it looks like. I apologize a little bit that it is not very nice to see. However, what we do for safety check, so that the tamponade is not forgotten, the patient receives a colorful armband, which is only removed when the tamponade is removed. We also place a suture to mark the end of the gauze so that we clarify that all of the tissue is removed. We never had a repeat episode of bleeding after the removal. And you can see here the final image of the entire uterus, the empty uterine cavity, no refilling of blood, no retained placenta as well. So just to give you an overview, before the introduction of the Celox and Bakri, we had approximately 9 hysterectomies due to atony in the years before, and after the induction, we had only 2. So it is really changed our management protocol that we start in the majority of cases with this gauze, even it is not FDA approved. Now let's come to another very, very important issue. Everybody's talking about reducing the numbers of C-sections and repeated C-sections because we have a 75% chance to deliver vaginally. Okay, that's the good news. But the bad news is if you experience a uterine rupture, and I promise you I've seen several of them, it is very often a catastrophe. And this is what obstetricians really are afraid of. And therefore, we have a very, very strict protocol to observe and a counsel to observe do good surveillance during the vaginal delivery after C-section. So each vaginal birth after C-section needs the attendance of an experienced obstetrician because of the potential risk of uterine rupture and the need of immediate diagnosis and therapy. Therefore, a routine ultrasound scan of the intact uterine wall and the lack of free fluid in the abdomen should be documented after a VBAC. This case shows a uterine rupture in the uterine fundus in a patient with a previous resection of a fibroid. And I'm even more afraid of patients after resections of fibroid than after a C-section, because in the areas where these are removed are very sensitive to contractions, and even more, the majority of these rupture at the time of non-contraction. So sometimes in between 34 to 36, 37 weeks, and it is absolutely independent if the uterine cavity was opened or not when you disturb the integrity of the myometrium. However, in cases of uterine rupture, free fluid in the pelvis is visible here by ultrasound in this case. And you can see this is the closed uterine scar from the C-section, from the previous C-section. And this is the rupture side here, the rupture side of the myometrium. And it was proven by CT, and the patient received immediately laparotomy. We closed the uterine wall and she preserved fertility, and the hematoperitoneum was removed. Now let's come more to the more common things, and these are retained products of conception. And nobody can tell me that he can touch this with fingers, as I read in the comments. Retained products of conception as a cause of late postpartum hemorrhage occur approximately in 1% of spontaneous deliveries. The retained products of conception can be seen in B mode as a hyperechogenic mass, in color dope with a feeding vessel, in 3D where you can see the invasiveness of the placenta into the myometrium. That's the reason why it was not delivered complete. And however, if you perform a removal, we perform it under ultrasound guidance, really to make sure that we removed all parts and that we do not perforate the uterus. But retained product of conception can also rarely be found after a C-section, as you can see here. This is always embarrassing for the obstetrician when he left something behind in the uterus during a C-section. However, it occurs, and it can occur. And you can see here the images are comparable with pictures after spontaneous deliveries. I took this case because you can see again the mass, the perfusion, the blood flow in the mass, and these are the clots. They need not to be removed. You will get them out just with misoprostol, with some also not FDA approved prostaglandin to empty the uterine cavity if you need. However, you see it is sensible to remove these under ultrasound guidance to avoid perforation in the area of the closed uterotomy. Now I come to my two last cases. In this case, a pseudoaneurysm was the cause of a late postpartum hemorrhage 4 weeks after an emergency C-section. The B-mode showed in the transvaginal scan a 2 centimeter cystic structure. You can see it here. This is the uterine cavity. This is the uterus, relatively small, but this is the cystic structure. And independent, if it is a vena galeni in the fetal head, everywhere, also in the tube or in the ovary or anywhere, if you see cystic structure, put the color on. And if you see turbulent flow, you will have to be very, very careful, because these pseudoaneurysms, they can rupture. And the color Doppler reveals the cystic structure as the uterine artery pseudoaneurysm. Just imagine if you would attempt a curettage. The patient rejected, in this case, for an interventional embolization, and a hysterectomy was performed to avoid uncontrolled rupture. Now, my last case, just to complete the differential diagnosis of late postpartum hemorrhages. This is the ultrasonograph finding of a uterine arteriovenous malformation. Include a normal appearing endometrium and a myometrium containing multiple hypoechoic or anechoic spaces, and with color Doppler imaging demonstrate a mosaic pattern representing the turbulent flow with high velocity and low resistance. This case demonstrates an AV malformation after a spontaneous delivery before and after radiological interventional embolization of the left uterine artery. It makes absolutely no sense to perform a DNC. So, in conclusion, and this slide I learned actually from Kypros. He's giving at the end of lectures very often one slide with all the wonderful images and soft markers for the down fetus with the nose and the duct and the maxilla angle and with all the other. In conclusion, postpartum ultrasound is a useful tool, as demonstrated with fast sonography in emergency situations. You need only 90 seconds actually to get an overview of the abdominal situation of such a patient who is unconscious. And I forgot to explain more in detail. Look at the vena cava of the inferior vena cava. Is it a very collapsed, less than 10 millimeters in diameter? You have a hypertensive patient. And if you have a dilated vena cava, you will have a hypertension, a pulmonary hypertension. Anyway, so in conclusion, in early postpartum hemorrhage, it can reassure that there is an empty uterine cavity immediately postpartum, and atony might be the reason for the bleeding. It can be used for an ultrasound-guided manual removal of the placenta or DNC. I know there are no studies which show the benefit. Note spiral arteries can be a cause of therapy-resistant uterine atony, and consider an abdominal scan after a VBAC. We perform this routinely now, and we haven't experienced that we missed a patient with a uterine rupture after C-section, after vaginal birth after C-section. So you can ensure an intact myometrium very easy. And in late peripartum hemorrhage helps to distinguish the ultrasound between hematometra, retained products of conception, the very, very dangerous pseudoaneurysm, and the AV malformations and placenta polyps. However, the last differential diagnosis, uterine inversion, I have no picture for that. So if somebody is in the audience of this huge audience of this, I heard about 17,000 people listening to us, hopefully. If somebody has a picture of a uterine inversion, I would appreciate to get this, and I would would mention it from whom I would have it. And so I thank you very much. I thanks also to the translators, because I know they had a very hard job to follow my bad English and my quick speed in the lecture. So thank you so much again for listening.
Wolfgang, your lecture was excellent, and your English is better than mine, so you are okay. A lot of questions on these CELOCs. How much does it cost?
Okay.
Are there any contraindications? Does it leave you with Asherman syndrome? What happens to people that have shellfish allergies?
Okay. So, I know.
And what is the percentage? And what is the percentage of your shares in the company?
Okay. So far now, I have no shares, but I can tell you the following thing. First thing is, the CELOCs cost at the moment, I don't know if this speech here, if this lecture will now increase the size, but this company is in United Kingdom. It's a neighbor from you. And it costs 40 euro. The roll costs 40 euro. The Bakri balloon, so far I know from Cook, costs about 200, 250 euro. I'm very, I apologize to Yusuf Bakri. I know him personally and I like him very much, but unfortunately, I have to say this tamponade has more advantages, which I showed. And the interesting thing is because it is out of the chitin material and not the myometrium of the shellfishes, and so there are no allergies observed. So there's absolutely no allergy to expect. And it is really interesting that we now have done a study also about the subsequent pregnancies. We have observed several pregnancies. We have no negative outcomes, no Asherman syndrome. The menstrual period comes again. I mean, the uterine cavity is used in a menstruating woman to recover and to clean it cell by itself. So we haven't experienced Asherman, we haven't experienced infections, we haven't seen any allergy reactions. For me, I really, I promise, it is absolutely helpful to reduce the bleeding, to stop the bleeding. And it is, I'm absolutely convinced from that, because it's very easy to insert. Our gynecologists are using it as well in earlier pregnancies or in cervix bleeding, for instance, in cancer patients where we need a local hemostatic tamponade as well. So, I mean, the company, they produce it actually for the battlefield. The military is the major customer, and they didn't experience that obstetricians could really use it. So they are very, at the moment, I think they don't expect that it might be useful, because it is normally only licensed for the external use. But the question is, where does external and internal starts? I mean, the uterine cavity or the vagina, is it external or is it internal? Is the area of the external genitalia, is it just external? Because it is licensed for knife injuries or for shooting injuries, and then you are allowed to put it in the canal of the stitch, and then you are actually also internal actually in use. So I think this is a problem which has to be solved. But I mean, as you know, misoprostol, for me, the second very important drug to stop bleedings, and very, very cheap. It costs only, I think, 20 cents one tablet, but it is off license. And the pharmacy is not interested in to get it on the market because it is in competition to the licensed products of prostaglandins. So, but misoprostol belongs on the top 10 medications to save mother's life. And I mean, it is a huge dimension. We need contraction medication to stop the bleeding, and we need local application of something which compresses the placental bed or to fill the uterus to stop the bleeding. And the big advantage of this stuff is, and this convinced me, that it is not dependent on the intrinsic coagulation system of the mother. The mothers are very often in DIC already when they lost 1 liter or 1.5 liter, and they have no coagulation capacity anymore. So, and this stuff is a good thing because it needs just some erythrocytes, some thrombocytes, some platelets, obviously, and this is enough to stop the bleeding and to close the bleeding area.
Thank you. Thank you very much.
Sorry, Kipros, can I make a comment? I'm curious about I'm very interested in all these ultrasound studies. Especially, I think it's a big problem in delivery that is shoulder dystocia. And it is any of the participants or the panelists that make these studies that they can measure or they can look how the shoulder are moving in the pelvis and how there is any engage of this shoulder in the pubis just to predict the shoulder dystocia. And think that because it's a very stressful moment for the obstetrician, the shoulder dystocia.
We have run a study on that. It's a small study, but it's the first study on that. We have looked at the direction of the scapula in a population that was at risk for shoulder dystocia. And we have seen that this is a very interesting finding because it's sort of rebuilding our knowledge on obstetrics. Using the transabdominal approach, the direction of the scapula can be upward, horizontal, or downward. It's very difficult to describe without having the picture. But based on the direction of the scapula, we can predict the interval. This is after the head delivery. We look at the scapula, and based on the direction of the scapula, we can predict the interval between the head delivery and the shoulder delivery. We did not have data on shoulder dystocia, but of course, on a larger population, I can expect that this direction of the scapula can be a marker of that. But there are also some data from Hong Kong. I'm not sure. I've seen Weilam Lau that was connected. He has nice data regarding the appearance of the humerus after the head delivery. And if Dr. Lau is connected, maybe Prof can give his data now.
And I have Professor Konstantin von Kaisenberg to make some comments on the stopping the bleeding.
Excellent lecture, Wolfgang. I really enjoyed it very much. Unfortunately, we had a case with amniotic fluid embolism. So we put everything into the uterus. We tried the Bacri and it didn't work. And then we tried the Xelox gas and also it didn't work. So we couldn't stop the bleeding. The only thing that worked eventually was the hysterectomy. So it does not seem to work in all cases. What is your experience? Did you have no exception at all where it didn't work?
Thank you, Konstantin. Actually, we had one case where it didn't work, and we applied additionally a Bacri balloon with a so-called sandwich technique in one uterus. So because the advantage of the Bacri is that you do not only compress the placental bed, you also can compress the uterine arteries a little bit. So this might be the effect of the balloon more than with the Celox. But I mean, amnion fluid embolism, you know, they are the catastrophes. They are really the top of the iceberg. They occur 1 in 15 to 1 in 50,000. But this is not really the daily work. I have experienced, let's say, 3 to 4 in the last 20 years. So, but the majority of patients, they bleed because of placenta bed bleeding, of retained placenta, of atony and so on. And amnion fluid embolism is really an exception. And very often the hysterectomy is the only way. On the other hand, not only the hysterectomy, you need a team from the anesthesiology department and from the hemostasiology department and from the transfusion department, that they give you all the help you need to get the coagulation system in order. You know, amnion fluid embolism is a so-called pulmonary collapse syndrome. You have an anaphylactic reaction in the lung, which gets thrombotic in all the micro vessels, and all the coagulation system is then taken into the lung, and this makes the pulmonary hypertension and the right ventricle asystole, and so it is very often fatal, independent of Bakri or Celox or something like that. But there was one very other important question. This was about contraindication. I haven't seen any really. I would really tell it to you because I have no. I just want to share with you my experience, and we did not experience any allergy reaction, and we have no contraindication seen so far. So I think it might be the only contraindication would be if you have really a wrong indication. So what means if you have a laceration of the uterine wall, for instance, after a C-section and after a VBAC, and you have an open injury area of your scar, then you might not stop the bleeding with this technique. So if you have a surgical problem, you have to open the belly and then perform uterine sutures, compression sutures, and you also can combine compression sutures with tamponade. We perform the technique also in C-sections. So actually we change already more or less into the internal use of the gauze. So if you perform a C-section, for instance, in a placenta previa, and we have placenta bed bleeding, we put the gauze into the uterine cavity via the uterotomy. We lead it out of the cervix, and then we close the uterus properly. And then you have to be aware that you do not stitch the gauze, but you also have to be careful when you do use the Bakri balloon in this situation not to stitch the balloon. So it is very, very, very easy to apply, and it is now in our clinic routinely actually implemented in the protocol. And I think in these situations where you really have a severe bleeding woman, these treatments are possible and allowed, even if it is not FDA approved.
Professor Lau has now joined us from Hong Kong.
Yeah, hello. Let me share my slide. Yeah, I try in the 12 patients. We can see in brief, we can see this is the first phase, and I do a longitudinal scan of the abdomen when the head is going to be crowned at the second stage. You can see the head, the humerus, the proximal one, you can see it's going horizontal and then going down, and then you cannot see it anymore upon crowning or shortly after delivery head. It is normal. This is also dystocia. You can see the proximal end of the humerus even after delivery of the head. So, but the interval between this this finding and the eventually discoverings of the dystocia from the obstetricians between the ends at the back end is very short. But it is possible to trace the proximal end. this is just a test of the theory, whether we can do so. Thank you.
Great, thank you very much. And Egebo wanted to say something. He raised his hand earlier.
Thanks a lot for this wonderful webinar. And I think these good lectures have convinced you that ultrasound add knowledge to the obstetricians. So I don't think it should be a question for the future if we should use ultrasound or not. The future should be to discuss and teach, to have better understanding how we should use this knowledge. This is the main problem. We have a lot of information, but we still don't know how to use it. So we should focus on this. Ultrasound adds knowledge, and this is also proven in a randomized controlled trial that ultrasound is more accurate than vaginal examination. So use ultrasound.
Tell me, this is a nice closing statement. In Norway, who delivers the babies?
The midwives or the normal ones.
And have you taught them how to use ultrasound?
Yes, I have started teaching them how to use it. And it's not so difficult to convince them. I always start with the transabdominal scanning and show them how easy it is to see the fetal position. And all the midwives will understand, of course, we need to know the position of the baby. It's important information. It's a bit more challenging for them to measure the angle of progression when they are not experienced. But this would be the future. But start with the transabdominal scan, look at the position, and as I said, it is also possible to look at fetal station from a transabdominal scan. And my supervisors, when I started, they always told me, do the transabdominal clinical examination to see how much of the fetal head is above the symphysis, above the pelvic inlet. You should always do this before an operative vaginal delivery. And it is so easy to see this with ultrasound.
Ali, I can see you smiling there. Do you want to say something?
No, I was smiling because I'm happy about the webinar, but I had a question for Wolfgang. It's just a rapid question. Because my experience in the postpartum in atony, that there are two groups of atony, the lower segment atony and the global atony of the uterus. And in the lower segment atony, the efficacy of the Bakri balloon is, from my experience, is 100%. Okay, Bakri balloon, and when it displaced downwards, it's not only harmless, actually it's beneficial. Okay? And when you have a global atony, this is where sometimes it fails. Do you have a comment on that?
You are absolutely right. The refilling by spiral arteries, the total limb uterus, and the lower uterine atony in the lower uterine segment, these are the three big atony types. I absolutely agree. The balloon works in this lower uterine segment atony as well. You have to be careful when you have a scarred uterus, because there are publications about where in scarred uterus, the balloon ruptured the scar and were found in the abdomen. So you should insert the balloon under ultrasound guidance. You should look at the end where it is located, and you should be aware of scarred uteri. And we had the Bakri balloon before, now we have the Cellox. So we changed our management because it's cheaper, easier to do, less painful. And there was one question in the audience. They asked if I used it in a septic patient. I mean, sepsis is a big different issue and problem. But I mean, if you have a patient who receives then the best antibiotics, has a good anesthesiologist, had a good fluid management, and you can try to avoid the hysterectomy, which is also not so easy in septic patients. You can try, but you have to be careful. I mean, it's off-label use. You have to explain the mother what you are doing, and she has to convince, and you have to have an informed consent with her. We had also infected uteri, the application in a few cases, and we had no failures in that. And I want to say one thank to Mahantesh Kharoshi. He's a colleague from London. I hope that he's listening to our webinar. And he gave me the advice with the armband, if you use a foreign body in a woman, because sometimes if you use foreign bodies, the duty is over, you go at home, and the next day the patient does not bleed, everybody's happy, and she wanted to be discharged. And so we have a lot of litigations because of lost foreign bodies everywhere in the world. So I strongly recommend, if you put anything in a woman, make an armband around, and when you remove the thing what you remove, then you can remove the armband as well. And if you do two things in the woman, Kypros is smiling, I know why. When you put two things, then you take two armbands. And I experienced one case where we put a Bakri balloon, and very often you use towels into the vagina that the Bakri balloon does not dislocate. And I had one case where the colleagues the next day removed the Bakri balloon but forgot the towel in the vagina. So what happened, 1 or 2 days later, she had a bowel obstruction, and the surgeon came and wanted to open the belly to remove the bowel obstruction. And then a trainee examined the patient and saw a small piece of a towel coming out of the vagina, and removed the towel. And after the removal of the towel, the small bowel obstruction was solved. So be careful of pieces you put into any orifice. And thanks to Mahantesh, and this shows that England actually, or United Kingdom, is always on top.